this webinar about musculoskeletal ultrasound in medicine. Thank you for watching. My name is Mark Schmitz. I research and lecture musculoskeletal ultrasound and anatomy at Vantis University of Applied Sciences in Eindhoven, the Netherlands. Next to my university work, I have my own company, KineCare. KineCare teaches both basic and advanced musculoskeletal ultrasound courses to healthcare professionals. KineCare teaches on a regular basis in the Netherlands, Germany, Switzerland and Italy, sometimes also in other countries. The goal of this webinar is giving you a better insight what exactly musculoskeletal ultrasound is, how it relates to other medical imaging techniques, and how it can benefit you in some steps of patient care. This webinar will contain a practical part where I will show you the ultrasound appearance of a variety of anatomical tissues. I will also show you a few ultrasound examples of supraspinatus pathology. Healthcare professionals need to possess more than just their clinical expertise if they are to meet the demands of the changing healthcare system. The use of evidence-based practice may improve healthcare quality, reduce medical errors, help balance known benefits and risks, challenge views based on beliefs rather than evidence, and help to integrate patient preferences into decision-making. In this era of healthcare utilization, healthcare professionals are expected to integrate clinical experience with explicit use of research evidence in order to make clearly informed decisions to help maximize and optimize patient well-being. Evidence-based practice requires studying the latest evidence in literature, integrating this evidence in practice, having a self-critical view, and applying clinometrics. Clinometrics is quantifying clinical symptoms and physical signs by applying measurement instruments with sufficient methodological quality. This measurement instruments can have a diagnostic, prognostic and evaluative goal. A few examples of measurement instruments could be questionnaires, using a goniometer, but also measuring on structural level with medical imaging. Several imaging techniques are available. In this table, one can see some advantages and disadvantages of several medical imaging modalities. Ultrasound appears to be the best option for extra-articular soft tissue problems due to several advantages. And it's more patient-friendly than MRI. Because of its advantages, its patient-friendliness, its technological improvements, and its decreasing price, ultrasound made an impressive growth in several healthcare professions. Here you can see Medicare data in the US. Can we still use our clinical tests in patient examination? Yes. Please keep on doing these, but be aware of the limitations. High-quality research shows that in plenty of cases, the diagnostic accuracy of the physical examination we do in musculoskeletal healthcare is limited. The words ultrasound, ultrasonography, and sonography are all synonyms. This webinar is about ultrasound within the musculoskeletal domain. Musculoskeletal ultrasound, in short, MSU. MSU is a medical imaging technique used to visualize soft tissue structures in order to capture their size, structure and function with real-time imaging. In this slide, you can see an MSU scan of the upper leg. In the upper left image, a transverse view of the femur and all four quadriceps muscles can be seen. Ultrasound technology is rapidly advancing and being refined and is aimed at both increasing image quality and opening new fields of applications. So what equipment do we need for MSU? First of all, we need a transducer. Transducers come in various shapes and dimensions and are designed for the body parts they have to assess. For MSU, we generally use the straight linear transducer. The transducer is an essential element of the ultrasound equipment, responsible for the generation of an ultrasound beam, which is sent into the body and going through various soft tissue layers, like skin, fat, muscle, and tendon. Bone is hard and can't absorb the ultrasound beam, so the bone will reflect the beam. The transducer detects the returning echoes and sends the signal to the ultrasound system, where all information is processed by the software. After processing, the image can be seen on screen. The whole process of sending, receiving, and processing happens so fast that there is no delay. All structures can be scanned and visualized real time. There is a big variety in ultrasound equipment. There is a variation in price, in size and portability, in quality and functionality. Some have a touchscreen. Other systems work as a laptop. Some are more designed for one type of medical field, others more for musculoskeletal examination. Today, we choose to work with this model.
Let me show you a few examples of scanning some anatomical tissues. Gel is applied to the transducer to improve the quality of scanning. The transducer is placed on the quadriceps muscle to have a transverse view on all quadriceps muscle bellies. Two quadricep muscle bellies can be seen: the rectus femoris and the vastus intermedius. Note the bright, white epimysium connective tissue sheets surrounding the muscle bellies. In the very depth, you can see a very wide, half-round line. This is the femur shaft. We will sweep the transducer towards the knee. This results in the rectus femoris getting smaller in cross-sectional area. In this position, you can see a smaller rectus femoris. The underlying vastus intermedius, the vastus lateralis on the left, and the vastus medialis on the right. Let's sweep the transducer medially and focus on the vastus medialis. And after this sweep laterally, to focus on the vastus lateralis. Can you see the little white fibers inside the muscles? This is endomysium, connective tissue surrounding the little muscle fibers. We go back to the central upper leg to see the rectus femoris again. Now a small muscle. The underlying vastus intermedius is still quite big. See the gradual changing of the darker rectus femoris muscle belly into the wide quadriceps tendon if we sweep the transducer towards the knee. The wide quadriceps tendon can be seen very clearly in the middle, with on each side the darker muscle bellies of the vastus lateralis and medialis, and the vastus intermedius below surrounding the femur shaft. Let's adjust the settings of the system and assess something other than muscle. Let's have a look on the patellar ligament. Ligaments should be scanned while on stretch, therefore this knee flexion. See the bright white horizontal line at the top left of the clip. This is the patella. Bones can be penetrated by the ultrasound beam, so the ultrasound will be reflected. Because of this, a big black acoustic shadow can be found behind all bones. The patellar ligament attaches to the patella, and the gray patellar ligament fibers can be followed horizontally to the top right side of the screen. Let's follow these fibers towards the attachment on the tibial tuberosity. Can you see the thickness of the patellar ligament and its insertion on the tibial tuberosity? See the white fibers of the patellar ligament. Underneath the patellar ligament, a gray mass can be seen. This is fat. The foot is placed in the end range of dorsiflexion to create a stretch on the Achilles tendon. This enhances the depiction of the tendon. The long, curved white bright line is the bone of the calcaneus. The Achilles tendon inserts at the calcaneus and its parallel fibers can be seen horizontally towards the left. We follow the Achilles tendon fibers to proximal. The gray and white horizontal fibers is the Achilles tendon. Note the dark gray and black part in the superficial part of the tendon. This appears to be a zone with less quality, maybe even pathology. A healthy tendon always looks white or light gray. Black indicates a intratendinous swelling. Underneath the Achilles tendon, the soleus muscle can be seen. Do you see the muscle fibers flowing into the Achilles tendon and creating the tendon-muscle junction? At the bottom, just below the soleus muscle, the flexor hallucis longus muscle can be seen. We can activate the muscle a bit by flexing and extending the hallucis manually. Scanning the median nerve in the carpal tunnel can be useful when carpal tunnel syndrome is suspected. The median nerve is assessed on size, color, and mobility. In the middle of the screen, we can see a bright white line. This is the lunate bone. In the top of the screen, right above the lunate bone, we can see a darker oval structure with white connective tissue surrounding it. This is the median nerve. We ask the patient to flex and extend his fingers. Due to activating the flexor muscles, the median nerve will move inside the carpal tunnel from left to right, which is correct anatomical behavior. See the median nerve moving from left to right and the underlying flexors rotating around their axis. We can follow the median nerve in its course to proximal. The median nerve can be seen as a white honeycomb-like structure at 1 cm depth in the middle of the screen. Here we rotate the transducer longitudinal, which allows us to see the median nerve in its full length with beautiful long nerve fibers instead of its cross-sectional area. Activation of the flexor muscle above and below the median nerve show some connection with, or influence on, the median nerve. The dynamics of the nerve can be assessed. The transducer is rotated back to transverse position. Try to follow the median nerve as we sweep the transducer back towards the wrist. The ventral elbow joint has lots of different anatomical tissues. Now I will show you an artery, muscle, capsule, synovia and bone. In the middle of the screen we can see two wave-like white lines with between them a black line. The lower white line is a trochlear bone. The black line is a combination of cartilage and synovia. The upper white line is the elbow capsule. The cross-sectional area of the brachialis muscle is the dark mass in the middle of the screen. When using the color Doppler mode, we can visualize the pulsation of the brachial artery. We rotate the transducer from transverse to longitudinal position. Now all soft tissue structures can be seen in their full length. At the top, the brachial artery with the underlying brachialis muscle. See the beautiful fibers inside the muscle. Underneath the brachialis muscle, we can see the elbow capsule, in white, and the underlying round-shaped trochlear bone. Left from the bone, we can see the coronoid fossa. Right from the bone, we see the coronoid process. One of the most commonly involved tendons is the supraspinatus. I will demonstrate one of several techniques to assess the supraspinatus. Please see the two most white lines in the middle of the screen. The lower one is the humeral bone, to be precise the greater tubercle on the right and the humeral head on the left side. The upper white line is the bursal sheet of the subacromial bursa. Between the two white lines, we can see the supraspinatus tendon attaching to the greater tubercle on the right. Let's have a closer look on this supraspinatus insertion. If we follow the supraspinatus to the other side, we can see it disappearing underneath the acromion. The subacromial space can't be assessed as ultrasound can't pierce through bone. Follow the dark shadow up and you'll find the top of the acromion as a wide curved line. Advantage of ultrasound is scanning real time. What happens with the supraspinatus while making an abduction movement? Subacromial impingement can be assessed in this way. See the supraspinatus gliding into the subacromial space underneath the acromion.
MSU comes with a high general diagnostic value, equally to MRI. The high diagnostic value of ultrasound is strictly related to a few important criteria. MSU's diagnostic accuracy is not profession dependent, but user dependent. Anybody can do it as long as they fit the criteria described on this slide. But only as they use MSU a lot, since there is a long learning curve. This long learning curve goes for every profession. MSU is a preferred imaging technique in extra-articular soft tissue problems. Capsular problems can also be assessed with MSU, but MSU is limited here. Intra-articular structures are hard to assess with MSU. Most of the times it's even impossible. MSU is not only suitable for diagnostics, but also for lots of other reasons. I will explain a few of these as an example by using pathology images. I can show you hundreds of different anatomical structures and even more pathologies, but let's keep it clear and simple. Let's focus, as an example, only at several normal, everyday pathologies of the supraspinatus tendon. On this slide, a healthy transverse supraspinatus is presented. Please memorize this picture. An accurate diagnosis is not that simple, due to the complexity of the anatomy and biomechanics of the human body. This is a right-sided, most likely partial tear of the supraspinatus, with as a result the intratendinous swelling. Hence, the darker, hypoechoic color and increased thickness of the tendon. The tendon is 9.8 millimeters. The normal average is around 5 to 7 millimeters. Relatively, this is a big increase which influences the subacromial space with as a result a subacromial impingement. The left side shows an old partial tear which seems to be repaired with fatty infiltration. This influences the loadability of the tendon and thus the training load we should apply. The bursa seems to be chronically irritated and the clinohumeral capsule appears to be swollen. All these specifics are important for clinical reasoning. Is an anti-can or Job test, a test with good diagnostic accuracy, capable in revealing all these specifics? Unfortunately not. MSU changed my view about diagnostics and treatment. Now I know much better what I can treat and what I can't treat. My success rate has increased enormously because I only treat the patients which I can actually help. Knowing one's limitations is important in preventing false positives, false negatives, overloading the patient, overtreating, and treating if there is no indication for care. This patient had a lot of pain on both sides, left more than right. Big intratendinous calcifications can be seen. Of course, these calcifications are not the only cause of the pain, but they certainly interfere. How successful would conservative therapy be in such a case? Patients will ask you how long it will take the complaint to heal. How sure are you about your answer? Maybe you rely on the connective tissue repair phases, but then you presume that the complaint can heal totally. This is a young professional tennis player. He is right-handed and since 2 years having increasing problems with his service. The MSU scan shows a partial tear, which with training most likely will heal in about 6 to 8 months. The changes in the humeral head, however, are definite. These will probably affect the mobility permanently. Research suggests that intervention such as giving visual, verbal, and written information can improve adherence to therapy and lead to a better understanding of the complaint. This increases patient satisfaction, results in a better treatment outcome, and it prevents false expectations. When do we stop therapy? Which indicators do we use? Pain, quality of life, time? MSU can help a bit in this decision making. Here you can see the shoulder of a professional gymnast. After 3 months, a perfect supraspinatus quality can be seen on both sides. At the right side, a minor bursa sheet thickening can be seen. This results in a tiny friction with the acromion with active shoulder adduction. The patient was given advice and some exercises and treatment was stopped. It's very important to understand that MSU has also limitations. Therefore, to me, evidence-based medicine is the combination of a good clinical examination and a MSU scan and applying clinometrics. Altogether, this can clarify every domain of the ICF framework. There are lots of advantages of using MSU. A few of them can be seen on this slide. The most important one being able to scan real time, which is a real added value during your clinical examination. The ability to do statistical measurements and to compare left with right in one screen gives a much better insight in the pathology. Disadvantages would be the long learning curve and not being able to scan intra-articular pathology. The systematic application of MSU to image the musculoskeletal system is changing our understanding of the pathogenesis of soft tissue changes, degeneration, and diseases. It is also influencing clinical practice and increasingly used as diagnostic aid and in the differential diagnosis of clinically undiagnosed problems. There is emerging evidence that this modality will form an essential component of outcome measures for therapies. MSU is a fantastic tool which will improve your skills and knowledge, brings more patient satisfaction, and it's a good business opportunity when used smart and in a qualitative and patient-centered way. A special thanks to ESA Ote, manufacturer of ultrasound systems, for powering this webinar. I hope you enjoyed it. Goodbye.